stomach contents can, to some extent, come up into your esophagus, which is considered physiologic. But pathological reflux is associated with symptoms and mucosal damage. Gastroesophageal reflux disease, GERD, is a condition that develops when reflux of stomach contents causes uncomfortable symptoms and/or complications. The pathophysiology of GERD is multifactorial and is best explained by several mechanisms, including the effect of the tone of the lower esophageal sphincter, the presence of hiatal hernia, esophageal mucosal defense against reflux, and esophageal motility. The lower esophageal sphincter, ileus, is a specialized muscle segment located at the junction between the esophagus and stomach, known as the esophagogastric junction, EGJ. It plays a crucial role in preventing the reflux of acidic stomach contents into the esophagus. Under normal conditions, the ileus maintains a constant contraction, keeping the passageway between the esophagus and stomach tightly closed. This creates a barrier, known as the physiologic EGJ barrier, which prevents the migration of stomach acid into the esophagus. This is like a muscular valve that keeps the contents where they belong. In addition to its barrier role, the ileus also helps food pass from the esophagus into the stomach. It achieves this through transient relaxation, meaning that it briefly relaxes its contraction in response to the presence of food. This relaxation allows food to pass through the ileus and enter the stomach. However, transient ileus relaxations, plessors, may occur frequently in individuals with GERD symptoms, independent of swallowing. These relaxations are not associated with the normal passage of food and can cause a disruption in the proper functioning of the ileus. During plessors, the ileus temporarily loses its tone and relaxes even when there is no food to pass into the stomach. This relaxation leads to a decrease in pressure within the ileus, allowing the pressure in the stomach to exceed that of the ileus. As a result, the acidic contents of the stomach, including stomach acid and partially digested food, can reflux or flow back into the esophagus. The classic symptoms of gastroesophageal reflux disease, GERD, are heartburn, pyrosis, and regurgitation. Heartburn is a common symptom in people with GERD. It is described as a burning sensation that usually occurs in the retrosternal region. This sensation can spread into the throat and may be accompanied by a sour or acidic taste in the mouth. Heartburn is often triggered after eating. Regurgitation is defined as the perceived flow of refluxed gastric contents into the mouth or hypopharynx. Patients typically regurgitate acidic material mixed with small amounts of undigested food. Other symptoms of GERD include dysphagia, chest pain, water hammer, globus sensation, odynophagia, extraesophageal symptoms, e.g. chronic cough, hoarseness, wheezing, and infrequently nausea. GERD-related chest pain may mimic angina pectoris. Complications can arise from direct inflammation due to reflux or as a result of the repair process. Erosive esophagitis shows erosion and ulcers on the mucosa. Barrett's esophagus is a condition in which the stratified squamous epithelium that normally lines the distal esophagus is replaced by metaplastic columnar epithelium. Metaplastic epithelium is acquired as a consequence of chronic GERD and predisposes to the development of esophageal cancer. In this disease, peptic stricture refers to the narrowing of the esophageal lumen due to the development of scar tissue. GERD is common in patients with asthma and has been identified as a potential trigger for asthma. Laryngologic complications can occur as a result of laryngopharyngeal reflux, LPR, of gastric contents and subsequent contact injury to the pharyngeal and laryngeal mucosa. Patients with chronic laryngitis present with altered voice quality or hoarseness due to LPR. LPR can result in laryngeal and tracheal stenosis. The diagnosis of GERD can typically be based on clinical symptoms alone, especially when patients present with classic signs such as heartburn and/or regurgitation. However, further evaluation, such as upper endoscopy, may be necessary if patients show alarm features, have risk factors for Barrett's esophagus, or have abnormal gastrointestinal imaging to assess their symptoms. While GERD may present with additional symptoms such as chest pain, globus sensation, chronic cough, hoarseness, wheezing, and nausea, these symptoms alone cannot serve as a clinical diagnosis for GERD in the absence of classic symptoms of heartburn and regurgitation. Alarm features suggestive of gastrointestinal malignancy include the following: new-onset dyspepsia in a patient over 60 years of age. Signs of gastrointestinal bleeding, hematemesis, melena, hematochezia, fecal occult blood, iron deficiency anemia, anorexia, unexplained weight loss, dysphagia, dinophagy, persistent vomiting, gastrointestinal cancer in a first-degree relative. Certain lifestyle and dietary changes can often help relieve GERD symptoms. If you have mild symptoms, you can try these approaches before seeking medical help. If your symptoms are more severe, it is a good idea to talk to your healthcare provider before making any changes. Losing weight if you are overweight or have recently gained weight. Raising the head of your bed 6 to 8 inches. Avoiding foods that trigger symptoms. Quit smoking. In addition to lifestyle changes, initial treatment of mild GERD includes the use of over-the-counter antacids or histamine receptor antagonists. People with more severe or frequent symptoms, complications related to GERD, or mild symptoms that do not respond to the above medicines usually require treatment with a medicine called a proton pump inhibitor, PPI. Lifestyle changes may also help. Once your healthcare provider has determined the most appropriate dose and type of PPI for you, you will probably continue taking it for at least 8 weeks. Longer treatment depends on if and when symptoms return after stopping. Treatment for GERD during pregnancy starts with lifestyle changes. If this does not relieve symptoms, your healthcare provider may recommend antacids or alginates. If the above measures are not effective, your doctor may recommend a histamine antagonist followed by a PPI if necessary. Although both classes of medication are safe during pregnancy, the general strategy is to avoid all medication during pregnancy if possible. Surgical treatment of GERD has a limited role, as lifestyle changes and medications are very effective in controlling symptoms in most cases. In general, anti-reflux surgery involves repairing the hiatal hernia, if present, and strengthening the lower esophageal sphincter.